Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome to episode 2 of Glass Level Podcast. Thanks for joining us again. Today we'll be discussing some hopefully interesting clinical cases and if we do anything differently or what we've learned from them. So,
yeah,
Mehdi, do you have anything on mind?
I think, I have one that was like really interesting.
Cool way to play off the fact that we've not been discussing this and prepping the minute for it. Nice off the cuff.
No,
Wait,
no.
are we supposed to have some case ready?
I'm just trying to I was thinking about what is quite rare. So like
because
your
you want to seem
papilledema
special and
like
interesting.
Yeah, because it needs to be interesting. Like,
Okay, go on.
My interesting patient is this woman in her mid-20s who, this is my old store. They came to see me, not specifically, but I saw them, and they were complaining of double vision, intermittent, and onset 2 weeks. But the double vision, when I say intermittent, it was there for like a good few hours, and it was all positions of gaze, like full-on double vision, and then like horizontal, I think it was.
Binocular.
Binocular.
With or without RX?
He didn't wear any glasses. Spectacles.
Spectacles.
Did you have a prescription?
These are the questions.
She had like an 075 or something.
Not
Like it would not have affected her symptoms. Like it had no connection to her symptoms.
These are the questions you need to ask in a history and symptoms for a double vision for all the pre-writers out there.
Yeah, I was gonna say, if you had to remind us to qualified optometrists,
Yes.
they shouldn't be in the testing room.
Yeah, if you were thinking, oh yes, really good question about how long's it been happening?
Is it monocular?
Just you right. You're asking about glasses.
Yeah.
Go back and do some CPD.
This is groundbreaking after starting.
Anyway, okay.
Binocular diplopia.
Binocular diplopia.
20s, no RX, doesn't have an RX.
Yeah, like no significant.
What other questions would you ask in history and symptoms for a double vision?
Yeah, what would you guys ask? I don't remember exactly what I asked because it was like 6 months ago. But...
Horizontal, vertical, with or without RX, distance and near.
Just everywhere. It was all gaze positions.
Which gaze position was with horizontal, vertical, monocular, binocular, with or without RX, distance and near. They're the main four. Onset, other symptoms, associated symptoms. Ask about headache.
A little bit more information about when it comes on because that's intermittently for a few hours.
Random.
Constant or intermittent. That's another one.
But it happened. It never happened in the evening. It always happened like in the day.
See, that's useful information. Like, what are we doing when it's happening?
Yeah. It happened randomly in the day. So it wasn't like.
Was it associated linked to task or?
No, because the onset was when she was on holiday.
Oh.
That was it. So I was like, maybe it's like she's doing lots of work, I think, but she was literally just on holiday.
Yeah.
And she just get double vision. And she went to the optician while she was on holiday, and they were like, we can't do any like additional tests here because you're not going to be here for that long. So go to your doctor in the UK and get a head scan.
Just straight off the bat, head scan.
Yeah, they said that because they couldn't find anything. Anyway, so they go to the GP.
Do you know if she had any motility done?
No, I just know that's what the optician told her. She goes to the GP here. GP's like, we'll run you up for some tests, but she also came to see me, so she's awaiting. Within that time. So she's not had any scans or anything like that done yet. And I'm like, okay, interesting. So start off with visions, pretty normal. Prescription, nothing that relates to it. Motility, literally normal, full, smooth, no pain, no double vision. Yeah. And also she claimed that after that 2 weeks, so when she came to see me, she's like, I'm not really getting it anymore. Like it's kind of like gone away.
Wow.
Yeah. And I do
fixation disparity?
No. I did a cover test. That was normal as well.
Okay.
So right now the patient's completely asymptomatic.
Everything,
can't pick up anything.
Yeah, nothing. And I'm not picking up anything. Everything's okay. I think I did fixation disparity actually. Because I remember I was like, okay, maybe there's like a hidden phoria or decompensate. I was like, I'll just rule that out. And I remember it being like single vision because she wasn't noticing anything. Even like NPC was normal.
Mhm.
I'm like, this is not what
You did
Why-
NPC.
I did
Why do you-
NPC.
why do you
This is
laugh?
how confused I was. I was
NPC,
like, what the
You
hell
did
is that?
everything. Throw it on
NPC
the
is a routine test.
This was
As in, I do NPC quite often. I think probably more than you guys.
you know, I actually do NPC quite a bit.
I do it when they have
Right.
headaches and when they've got like problems with reading. If they're young, I'll do NPC.
I do. Yeah, that's the thing. So I do NPC
Yeah.
quite a bit, unless
they-
they're
if they've
presbyopic
got
and they're like,
double-
oh,
like,
If
I
they've
go
got
with
double
the
vision, you've got
20-year-old.
it.
Huh?
Yeah, but if a 20-year-old's coming to you with double vision, you've got
yeah,
to
you do.
NPC.
I do NPC on like anyone that's like not presbyopic and has issues reading.
No, I don't think it's good to do blanket testing, but it's probably a good
But
idea to
like,
use it when clinically indicated.
But the thing is, that's true. But my thought process was like, well, there's no other BV test that I could have done. So
In this case, definitely.
let me rule
I'm
it
talking
out.
about just blanket
Oh
testing.
yeah, no, blanket testing is just a waste of time.
Exactly. It's not in the interest of the patient.
I'm not 100% sure if she was. I think she wasn't getting headaches, and then she started getting headaches, and now she's come with the headaches.
After the double vision stopped.
Yeah. But
Was
like,
she having any headaches with the double vision?
not really. Or like the headaches wasn't very like she wasn't able to describe it very well.
Standard.
Yeah, standard. But like it didn't follow any like telltale patterns of anything. So it wasn't something that I became. But because she was getting double vision, I was like, this doesn't sound right. So I was like, let me just do a field test. Oh, fundus looks fine. OCT looks fine. Everything looks perfectly normal. I think she was there previous because literally like nothing looked like discs weren't even blurry. Like perfectly fine. So I was like, let me just do a field test, and I get her to do a full field. Let me just rule it out.
Okay.
I even told her, I'm like, I'm not expecting anything to show up, but it's a good test to do. So if we find anything, we can just deal with it straight away. So that's fine.
What did you see?
I saw. Let me get the right name for it. So it was a quadrantinopia.
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 Not like a subtle field defect
No,
of like.
it was a
Hold on.
homonymous left quadrantinopia with macular sparing.
Inferior.
Inferior, yes.
An inferior left visual field defect. Quadrantinopia.
Yeah, but quadrantinopia is a field defect, isn't it? So.
It's not a hemianopia because then that would be.
No, it was a quarter of the vision was gone, which is probably why she hadn't noticed any problems because her macula was okay, and the bottom parts of her fields were gone. So
Macular sparing. Why does macular sparing happen? Pause this and think about the answer. And we'll be back in 5, 4, 3, 2.
1.
macular sparing. So, do you know the answer, Shrave, yourself?
Yes, but I want to see if you know it.
Okay, so the reason why there is macular sparing is because the
1, 3. 1.
1,
2, 3.
Dual
Dual blood supply! And also
Okay.
the fibers for
That's
the
gonna be so loud.
the macular fibers traveling through the optic nerve are more central, and the peripheral fibers are on the outside, so it's more protected from lesions. But please continue about your dual blood supply. What are the two arteries that supply?
You literally said them 5 minutes ago.
Yeah, I know them.
And I forgot.
Do you know them? The middle and posterior cerebral arteries.
Right. Middle and posterior cerebral arteries. That's the blood supply. So basically, hopefully the image that we can put there. Yeah. Or here. Or
Probably the entire thing just going to be
Yeah, I'll
image.
just-
So just superimpose the image overall.
yeah.
Number 9 is what we're looking at.
Number 9 was it?
Number 9.
Number 9, yeah. And that should create the homonymous
Macular sparing
quadrantinopia.
quadrantinopia.
That's it.
Yeah.
Inferior. It was quite congruous actually as well. So because the closer it gets to the visual cortex, the more congruous it gets as well. And it's quite interesting because it was congruous. Anyway, so with referral, what would you guys have done when you see that? Because everything else is normal. Like from my perspective, and after doing all the tests that are required, everything seemed to be normal except this visual field test.
Except the evidence of a potential lesion
Yeah.
in the visual pathway.
So,
Except for the massive homonymous
The massive
quadrantinopia with macular sparing.
Everything's fine except for the lesion in the visual pathway.
The
The patient's
gaping gap.
absolutely fine except for the fact we can't
Swim at the
see.
But you know what? It's quite interesting because it's an inferior quadrantinopia. And to be honest, if you think about it, if this part of your vision kind of goes away, it's pretty tricky to know about it.
I would argue the opposite. Everything we do with our hands is down here. Okay, it's a superior portion that for you would be less noticeable.
True, but if you have your macula, like if your macula works fine, you a lot of the stuff that you do is based a bit higher up.
Is it?
I think so. If you were to like read, you don't read with your periphery.
I don't read.
You move your eyes down.
I don't read.
No, of course.
Do you know what I mean?
When we look at something, we look through a macula. Of
Exactly.
course.
Yeah. So if I'm looking at this, I would not be noticing my iPad screen at the moment. And that might not be an issue for me if I have a quadrantinopia. If it's not like
The question that I had for you is, the comment that I had for you is, I was reading the comment section of a post. It was one of those surgical videos,
yeah,
and a surgeon had commented they were doing like a peel for
like the whole.
no, they were doing like a peel of a
ERM.
ERM,
Okay.
or some kind of they were doing some
DMT,
DMT.
ERM.
They were doing a peel, and the surgeon said I always start with the retina inferiorly when I'm peeling because if there's anything going to go wrong, I'd rather it go wrong in the superior visual field than the inferior one because
Okay.
the inferior one is more needed in day-to-day life. Because when you're walking around, you need to be able to look straight ahead and look down where you're walking. You don't need to look up.
True.
I was speaking with a friend and a colleague who has a visual defect.
A colleague had a visual field defect.
Yes.
Oh, I think you mentioned this to me, didn't you?
And they noted that I think it was a right quadrantinopia or hemianopia, something like that. They showed it to me. I don't recall. Rather not go into that. But they mentioned that they noticed it developing, and they noticed that it not being present due to bumping into things or things coming up out of nowhere.
So like you don't realize until like it's affecting your life.
But it's like it is noticeable, even though that wasn't. They could see straight ahead, etc.
Yeah.
We don't realize that the periphery, even though it's not what we're looking at, it does have an impact.
Yeah, but that's my point. My point is that there's the reason why she probably didn't notice it is because it's peripheral vision that's lost. Like, for example, with people with glaucoma, they end up getting tunnel vision. So when they realize that they can't see through the periphery, it's too late.
They've lost too much of the vision.
Yeah, but like with this, it's a there's a quarter of the vision gone, and I feel like she's not noticed it
because of the macular sparing.
Yeah, because of the macular sparing, and also it's only 2 weeks, so like it's just come and gone.
So with referrals,
what would you have done?
What did you do?
I did urgent referral, hospital, and then letter to GP.
I think that's quite appropriate.
Yeah, I think so too. What would you do if it was like a nerve palsy or something on the same day? You'd do the same day referral, wouldn't you?
You know, if I get confused, I just go on Annex 4.
If I get confused, I just give them a call. Honestly, the amount of times I just...
If in doubt, call your local eye centre or your on-call ophthalmologist and ask for clinical advice. This is a shared community responsibility within healthcare professionals. If you're not sure, there's no shame in not being sure of what to do in the moment. Just call them and ask them what they want you to do.
Yeah, I give them a call. I'm not annexing or
in my specific case, what would you do?
Same thing to you. I'd do an urgent referral.
Would you have done anything different?
I would have consulted with colleagues and things. I probably would have gone for urgent. If there was more going on there, I would have probably moved it to same day. If there was more.
Why?
As in, like,
and what do you mean by more?
As in, if you see for example, you see a third nerve palsy, what are you going to do?
Well, yeah.
It's like a sudden onset. As in, if they came in and they said, this morning I've got like coming and going double vision, and they've got a massive quadrantinopia. It was the onset. It was the fact that it was a 2-week onset.
Exactly. The onset does.
But I would write urgent, and I would mention the onset. And I'd let the my local referral scheme grade it up if they need to, the SPA.
Yeah.
So they always monitor it anyway. In Sheffield, you send it to the SPA, and they triage to secondary care, primary care, emergency eye centre.
What does SPA stand for again?
Single point of access. The base of the northern. So there's a PAIRS registered optometrist who every day sits down and goes through this pile of referrals.
PAIRS is Sheffield MEX scheme.
Yes, the Sheffield.
That ties in quite well with my case.
Oh, what's your case?
Oh, here we're still on my case.
Explain it.
Pretty so.
My case, the reason that it ties in quite well is because it's not something I would have referred same day,
Yeah.
except due to making a call to the on-call ophthalmologist,
Yeah.
they asked to see it same day,
Okay.
just due to the fact that they just wanted to have a look at
Yeah.
it.
Yeah.
But I feel that if I didn't make that call, and if it was the same situation in the future, something like that, it'd probably still do urgent.
Okay.
So my patient was 50s, female, East Asian, came first time eye test here. 5 months prior, had bilateral cataracts done,
Okay.
extraction, fake emulsification.
How long ago?
5 months
5
prior.
months. Okay.
Everything was fine after that until about 2 weeks ago, noting left eye blur.
Okay.
Left eye just wasn't as clear. Now, the patient hadn't had a refraction since then.
Okay.
I thought this was going to be quite straightforward.
PCO.
I didn't even think that. The patient's had the cataracts done, but not had a refraction since.
So you
So it
thought
I
needs
thought it was
fast.
just straightforward.
Yeah.
They said that they had their post-ops done, okay, at the hospital that they had their original cataract surgery done, and everything was okay.
unnamed private hospital.
It was abroad.
Oh,
Yeah, it was from
Definitely unnamed.
yeah,
yeah, we won't name that.
it was abroad in a different continent. They had the surgery abroad.
Yep.
They had post-ops done. No refraction, came in, no glasses. It was straightforward and simple. They noted that there was no issues until 2 weeks ago. Refraction, I got to the right eye 6.6.
Okay.
I expected better. 50s.
Yeah.
50s is not the issue.
Yeah.
6.6, even though, yeah, 20/20 vision
6.6.
6.6.
You
I
push-
expected
You push past 6.6?
all the time.
Of course.
My norm is 6.5. And
Yeah,
then if you're
mine's-
seeing 6.5, I 6.4.
Yeah.
Depending on where.
Well, you know what I do? I always try to go for 6.5, and then monocularly, and then binocularly, I get them to try 6.4.
Yeah.
That's what I do.
You get them to try.
Yeah, just get like if they get one letter
Because
right,
you
I
know,
know
if they're getting monocular 6.5, you don't need to show them 6.5 again binocular.
Yeah.
Unless you've done something grossly wrong,
Yeah.
binocular balance or something.
Exactly.
Every 6.5. May
Exactly.
as well go for 6.4. But pinhole, if pinhole doesn't improve, it's likely not refractive. It's likely pathological.
Yeah.
Not clinical advice. But yeah, so that was raising up alarm bells. So I was
Yeah.
like, pinhole's not doing anything. If anything, she's saying that it's seeing worse, which kind of makes sense. If you just restrict 90% of your field of view and things get worse, not too shocked with that. So yeah,
Usually you put the pinhole in the right place.
I asked them to orient themselves so they can see out of it, so they can see through the light.
Was it with a rupture or with a trial frame?
It was fraught, right? Just
When's the last time you touched the trial frame?
sorry.
When's the last time you touched the trial frame?
The place didn't have they had the phoropters, but there was like the manual phoropters.
Oh no, that's
Yeah, wasn't touching that. Got the
Yeah.
trial frame out. It was 20-minute clinic as well. But yeah, so asked them to orient themselves. They could see at the pinhole, vision was worse. So I knew that the refraction wasn't the issue. And I already had gone through before I tried pinhole.
Yeah.
I try refracting again, just sphere adjusting, etc. It doesn't take that long, so I'm quite happy to try it. And it was improving. 6.6 was right eye, 6.10 was left eye. So she did come in and complain about left
Yeah.
eye, rightly so. And then I just went on to posterior eye exam. And I'll be honest with you, it looked all too wrong. Okay.
Unremarkable.
Yeah, there was no CRVOs, there's no BRVO, there's nothing.
There's no VR.
No VOs.
There's no
no.
There's no VOs. There's no retinal attachment. I wasn't dilated at this point, but the lens was very clear. PCO cornea was clear, so I'm working my way through the eye. Fraction's fine, cornea's fine, lens or the intraocular lens implant's fine. Going into the retina, that seems okay.
Okay.
There's no hemorrhaging there. There's nothing present. There's no drusen.
OCT?
They didn't get OCT, but at this point I was like, I'm going to need an OCT done.
Yeah, because you're flustered.
Because
I knew that there isn't anything wrong with the media. There's anything wrong. But if anything's going on that's causing this, if it is pathological and not,
So they were 6.6, and you're like, this is weird.
No, the 6.10 eye.
Oh, okay.
6.6 was right eye,
Okay,
6.10 was left eye.
Yeah.
6.6, if that was all being done, I probably wouldn't have thought too hard about it. But the thing being, I didn't have any prior information as well. This is the first time they came to the clinic. If prior they're seeing 6.4, if they're seeing 6.4 then and seeing 6.6 now, and they're noting things have dropped and there's no cataract like that done, I probably would have investigated further. first time here, 6/6. You know, it's without too much more information, I wouldn't have stressed out too much about that.
Yeah.
But the left eye, I had to get OCTs done, and when I saw them, huge amounts of fluid in the macula.
Really?
I was quite because I looked at the
Post-operative CMO.
sorry.
Post-operative CMO.
That's what I was thinking. So I was thinking CMO. It's a complication when it comes to
Yeah,
cataract operation. Straightforward. Post-ops are absolutely fine. This happened 2 weeks ago. 4.5 months after the operation.
That's awesome.
Unusual.
Unusual, not
Yeah,
impossible.
of course. But also CMOs, yes, they're circular. Yes, they're the macula tendency. They're always really, well, not maybe not always, but they're subretinal, and they're quite neat.
Okay.
You know, it's quite a neat line.
These ones are, what are you talking about?
No.
General
Just
post-operative.
General what to look at
general,
for
CSRs. This one, there's a lot of intraretinal fluid, and that's what got me confused as well.
Yeah.
Because post-op everything's okay. This happened 2 weeks ago. Lots of intraretinal fluid, lots of subretinal fluid, more in the left eye, some in the right eye as well.
Okay.
Okay. And if I'm seeing it in both eyes, if you just had her left eye operated on,
Yeah.
okay, and this just happened in the left eye,
Yeah.
the right eye's not been operated on, it's fine. I think that's open and shut case CMO. But it's hard to say when it's bilateral because it could be pathological. It could be diabetes or something like that.
Was it bilateral or?
It was bilateral.
Bilateral. The right eye was 6/6.
It wasn't as intense. It
Oh,
wasn't
it
as
was
severe. It
milder
was a
one.
lot more mild.
So your patient, the CMO one, why? Because I would have done urgent. Like I wouldn't even think about it twice. I just urgent referral because there's fluid, send them out. Why did you think that you had to call the hospital?
So there's three things that were most likely in my mind. One most likely was post-operative CMO.
Mm-hmm.
The second one was potential diabetes. The
Okay.
third one was wet AMD. Just grossly. Okay, I'm not seriously considering all of these at this point. I'm just thinking fluid inside the macula. What could it be?
Yeah.
It's
either way they're leaving. They're off to the hospital.
Exactly. And the two of those things, okay, that's happening suddenly. I'd be more comfortable calling up the hospital.
Yeah.
If it's diabetes causing intraretinal fluid, I'm calling up the hospital. If it's wet AMD, I'm calling up the hospital.
You call the hospital for wet
Yeah,
AMD.
but why would you call the hospital?
You
I
don't
just
just
urgent
refer
refer them.
No.
Why are you calling the hospital? Because I only call the hospital if it's something that I'm like, should it be urgent?
But yeah, it was just a case of how do you want me to go about this? Is this just at this point I didn't discuss with the patient how long they were here for, if they're here for a bit longer or not. That's something I probably should have done.
Yeah.
But yeah, so then called the patient afterwards. I said, not the patient, the hospital, and said it was a CMO. So I wouldn't have expected to come that much later, and post-op would have been okay.
Fair enough.
But yeah, learned a little bit there.
Do you ever call the patient after you referred them just to follow up how they got on or what happened?
Yeah.
Not frequently, but I have done in the past.
Well, when I was in pre-reg, I think one thing that I don't know, I feel like it helped was when I had like an urgent referral or emergency referral, I'd leave it for well, if it was emergency, I'd leave it for like a week. And then after a week, I'd just call them up to see what happened. The patient.
Not the hospital to refer it.
No, I've already done that. I've already referred them.
I'll just give it a week.
I'll just give it a week.
We'll check out that third nerve
detachment. Well, let's wait 1 week.
We'll just see how that third nerve palsy gets on.
But so I've referred it and everything. But after a week, I usually just. This was in my pre-reg though. I used to call the patient just to see what they did. And for me, it was interesting because in my pre-reg days, it would kind of cement
Your
the
learning.
theories, my learning. So I'd be like, okay, so I saw this. Well, I found this symptom and this symptom, and I act this way, and it was this sort of pathology. And I think that really helped me. So one tip I think overall in pre-reg would be, if you can, just follow up.
Consider that as an option.
Yeah, consider just a follow.
Yeah, don't take it as clinical advice, but just think about it.
It's not really clinical advice. It's just It's also, you know what, the patients always love it as well because they're like, oh, this
good care.
exactly. They've got the courtesy. And
You've got their
door to
address.
check in.
Just go to their house. Just knock on the door.
Yeah, just knock on the door.
If the door's open, let yourself in. Bring cake though. Bring some food or soup. If it's a retinal detachment, soup is good for you. Don't ask me what study that was.
So, Shrey, tell us about your case.
So this is one that I saw today. A gent, 58 or so, male Caucasian, presented for a routine sight test. He said his current bifocals, were not strong enough. He felt like he was straining a bit on VDU. He worked as an accountant, so he had a lot of screen time in a day. He was semi-retired, so he said, I just want something a bit stronger so my eyes can feel a bit more comfortable. Plus 175 in both eyes in his existing specs, plus 225 on refraction, kept the ad the same. That was all fine. 150. He wanted an intermediate ad so he could work on VDU. He's happy to use plus 4 ready readers for his close work. And then when I got to ophthalmoscopy,
so no real issues, just a refraction.
Just a refraction, routine sight test, no symptoms, no complaints.
We said interesting patient.
On fundoscopy, I observed a lesion.
So you saw it on RET, on the Volk.
On RET.
RET?
What are you that good?
I saw the reflex and I thought,
The reflex doesn't look like a normal reflex.
So it's also worth noting that this gent had perfectly fine health. He had no health problems. He wasn't taking any medications. He had no history of any health problems. So this was truly a routine test on an asymptomatic healthy patient. There was a lesion at the macula in the left eye only. The right eye was absolutely normal. The OCT was absolutely fine. In the left eye, the OCT showed an area of hyperpigmentation and hypopigmentation in the central retinal layers. So there was some macular edema or intraretinal fluid and also some exudates. Given the location, these looked like exudates. They were
intraretinal fluid in the macula.
Intraretinal fluid at the macula. The main difference that you need to know is on OCT, a drusen would be subretinal in the RPE, and exudates would be hyperpigmentation areas in the retina. So these were in the retina, and there was little pockets of edema. So this is clinically significant maculopathy. My knee-jerk reaction was diabetes, which I did refer him. I gave him a letter in his hand to take to the GP surgery, requesting serum glucose, ESR, full blood count, blood pressure, to rule out diabetes and just to check for diabetes. Also, my initial reaction was to refer him to the diabetic retinopathy clinic at the hospital for assessment. And after some discussion with another colleague and after thinking about it, I referred him instead to what Sheffield has, is the Fast Track Macular Clinic for AMD. Now, a diabetic referral in the Sheffield guidelines for clinically significant maculopathy with no reduction in vision and nothing else, it's 13 weeks. But given the fact that the right eye was absolutely normal, there was no other signs of diabetic retinopathy, and for the possibility that it could have been this other thing, I've marked it as urgent and sent it as 2 weeks in the Fast Track Macular Clinic. We thought it could be a RAP lesion, which stands for retinal angiomatous proliferation, a RAP lesion. Now this is a type 3 neovascularization, because type 1 is occult underneath the RPE, type 2 is classic, which is above the RPE, subretinal, and type 3 is in the retina, so it's the retinal blood vessels that cause the
So what's the only thing we need to know?
hemorrhage and cause the edema. There's nothing you need to know.
How would knowing this in the future, how would this impact your differential diagnosis for things? Or
well, I'm curious to see how this one comes back. In a later episode, I might follow up with what I found out about this. But this is a really odd case because it's somebody who is not diabetic, who is presenting with what looks like diabetic retinopathy, but it could have also been a retinal angiomatous proliferation, a type of neovascularization in the retinal layers that's hemorrhaged and caused these exudates to appear. So there's not really anything to learn from it. It's just something to.
So I've I've never heard of a RAP lesion.
Never heard of it.
What causes it? What's
AMD
it?
is a type of AMD.
Is it okay?
So it's a type 3
Okay.
neovascularization of AMD.
Treatment, would it be anti-VEGF like AMD? Or
I'll tell you what the treatments could be. The potential treatments, medical therapy, retinal angiomatous proliferation demonstrates good response to antivascular endothelial growth factors, so anti-VEGFs.
should be the same treatment as the.
Yeah, it'll be treated as wet AMD.
So it's just a subsect
Of wet
type
AMD.
of, okay.
Yeah.
But
And
it's,
he's
instead
50,
of it being
he's 58.
58, instead of it being subretinal, so subretinal fluid and
Intraretinal,
plastic,
yeah.
it's intraretinal, and it's from the retinal blood vessels that go through the retina and supply the.
So what
ganglion
relevance
cells.
does diabetes have to this?
I've referred him to the GP for blood checks.
Diabetic
It could
work.
be
Is this
diabetic.
only a speculation that it could be this?
Well, the differential is diabetes or wet AMD.
So you just covered both tracks?
I've covered both
Okay.
cases.
Okay, that's fine. So
As in
this
I was-
isn't confirmed to be this?
Oh no, this is just what I've seen today, and my management could be wrong, but I've referred it in a more cautious approach, I think, by sending it to the fast track macular clinic to be seen within the next 2 weeks. I think that's probably more cautious than sending it routinely for diabetic screening. As somebody who's not diabetic,
I mean,
yet.
if it's affecting the macula, you kind of want it to be seen urgent.
Good visions.
Oh, really?
6'6".
At
So
this
did you-
point, you don't know how fast it's developing.
Did you were you only able to see the problem through the OCT? Like, if that patient did not have an OCT, would you have asked for an OCT, or would you have let
I
them
would
go?
have asked for an OCT because I would have seen on the fundus image it was very clear that central area of exudate.
Okay, so
It was
okay.
very.
So you could see something on fundus.
When you see an exudate, you really can't tell if it's an exudate or a drusen unless you're skilled like some people.
Thanks for tuning in today. Yeah, maybe you learned something, maybe you didn't. Don't act upon it, whatever you do. But yeah, hopefully see you in the next one.
See you later.